Good morning, good afternoon, good evening, everybody. Welcome to Hand in Focus. Today, with a very special edition of Hand in Focus in combination with the Asian Pacific volume of a Journal of Hand Surgery with the theme of tendon transfers. My name is Harvey Chim from University of Florida. I'll be moderating this session together with Eberlin from Mass General Hospital. We have a tremendous team from Asia joining us today. We have Dr. Michiro Yamamoto from Japan and Dr. Sandeep Sebastin from Singapore. And our expert from Asia is Dr. Yong Chuan, and from the US, Dr. Scott Kozin. So the first paper that we'll be discussing tonight is entitled Tendon Transfers, Nerve Grafts, and Nerve Transfers for Isolated Radial Nerve Palsy, a Systematic Review and Analysis. And we have the senior author of this paper, Professor Newford Jones from University of California, Irvine, joining us tonight. The second paper we'll be discussing is entitled Options for Restoring Finger Extension in Mangling Forearm Injuries. And we have Dr. Praveen Bhardwaj joining us today from India. Our US expert for tonight is Professor Scott Kozin. He's a world-renowned surgeon, a hand surgeon really in all aspects, especially in the area of tendon transfer, chief of staff at Shriners Children's Hospital in Philadelphia, as well as a past president of the ASSH. And our Asian expert is Dr. Yong Chuan, who is a senior consultant in the Department of Hand and Reconstructive Microsurgery at Tan Tock Seng Hospital. And Mr. Yong is an expert in brachial plexus, peripheral nerve surgery, as well as tendon transfers. And we're very happy to have him join us tonight. So the format for tonight will differ a little bit from previous editions of Hand in Focus. We'll first have, for each paper, an author presentation. This will be followed by a PowerPoint presentation by the first expert, followed by a comment from our second expert. After that, we'll have an author response to the comments by both experts, and this will be followed by an open question and answer session. So again, please mute your microphones. Please do turn your camera off while the speakers are presenting. Cameras can be turned on for Q&A. Please ensure your Zoom screen name is your first and last name. And please do ask questions in the chat. And the moderators will make sure that we try and address your questions as much as possible. This session is designed to be engaging and interactive. So again, please ask questions. So without further ado, I'd like to invite Dr. Jones to start us off with the presentation for the first paper. Dr. Jones, please.
Okay. Can you see that?
Yes, we see you great. We see your slides.
Okay. So I just would like to give credit to my co-authors, Nirbe Jain and Megan Barr, their plastic surgery residents at the University of California, Los Angeles, not Irvine. And also to Daniel Kim, who's a medical student, but they did all the heavy lifting in terms of doing the pulling the charts and the papers and doing the statistics. So if I can just get this off. And I can't seem to advance.
You might try the space bar. I think sometimes that works.
Can you use the arrow button?
I'm doing everything.
Oh.
Sorry about this.
Do
you want to switch?
Maybe you could try, we'll try one more thing. Could you try to stop sharing for a while and just reshare it again and see if your slides will work?
I don't have anything now at all.
Harvey, I can go first if it's easier when you'll fixes it, whatever you would prefer.
Yeah, we could do that. Thanks, Scott. Yeah, so please go ahead with your slides.
Neil, is that
Thank
okay with you?
Yes.
Okay. So I was to follow Neil's discussion on the concept of tendon transfers versus nerve transfers. And I thought that would be interesting. Can you see my screen now, Harvey?
We actually see an email,
Oh,
not
there you
your
go.
screen. Yeah.
Oh, wait, I got the wrong screen. Let's try this one. Here you go. How's that better?
Yes,
There
now
we
we
go.
see it.
All right, miracles do work, right? So I thought that it would be a nice segue after Neil spoke about the concept of nerve versus tendon. We are big fans of tendon transfers, and I thought would be interesting to the group would be to show an example of a patient that underwent tendon transfers, both pre-op, intra-op, and our surgical decision-making. So the child's name is Julia. She's a 10-year-old who presented to the Shrine in 2019. When she was 3 years of age, she developed idiopathic right radial nerve palsy. No real reason. There was no parsonage turn or something like that. It just happened. And it never recovered over time. And then she was sent to me for an evaluation. And I'll go through her physical examination, which showed the median and ulnar nerves are intact. I'll talk about the radial nerve, primarily brachioradialis wrist extension, finger extension at the metacarpal phalangeal joint, and thumb IP joint extension. So this is Julia. This is her preoperative examination. She's obviously on the right and I'm on the left. And what we're going through is just a basic examination, looking at her radial nerve. Her triceps is working, so it's a high radial nerve, but triceps is intact as you see here. So she's good, strong triceps ability. And I said before, her median and ulnar nerves are working fine. I'm looking here for the brachioradialis, which is mushy and is not really working, which is consistent with a high radial nerve. She has no wrist extension. She has IP joint extension from her intrinsics, but she has no metacarpal phalangeal joint extension. And it's one of the issues with finger extension is extrinsic extension is metacarpal phalangeal joint and intrinsic extension is at the IP joints. She's totally supple, which is just fantastic. Here I'm looking for her FDS tendons because our preferred technique involves FDS for wrist extension that we've probably done about 60 times now. We do not use pronator arteries very often. We tend to prefer the FDS for wrist extension. I'll talk a little bit about when we talk about our decision making. We also prefer the palmaris longus for thumb extension. But remember, it's not palmaris longus to EPL, it's EPL to palmaris. And there was our flexor carpi radialis, which is what we prefer for metacarpal phalangeal joint extension. So here's her assessment. You saw her examination with a high radial nerve palsy, distal to her triceps, but picking up from the brachioradialis, wrist extensor, finger extensors, thumb extensors. Our plan, take 2 different FDS tendons for wrist extension. Again, it's totally surpassed our pronator teres results. We transfer the EPL to the palmaris longus, not vice versa. If you transfer the palmaris longus to the EPL, you get too much thumb adduction, which is really bad. And then flexor carpi radialis is our preferred donor for EDC, more so over flexor carpi ulnaris, just based upon the muscle attachments of the flexor carpi ulnaris are very, very difficult. How do we base our selection? We base it on donor strength, so the donor has to be normal. We talk about muscle fiber length, which relates to excursion. For example, the FDS has great excursion and can easily extend the wrist. It has to be expendable, so there has to be something left behind that can compensate for the lack of donor deficit. And we really believe in synergism. This has been the biggest change about trying to use, for example, a finger flexor to extend the fingers. It's never worked for us. I don't think it ever will work for us, and we just don't do it anymore. So these are our basis for our selection that we reviewed. In terms of the FDS tendon, it's a super interesting transfer. We tend to pass one tendon through the interosseous one membrane and one around the radial side of the forearm that give you a little bit of pronation. This we published in JBS in 2021. We're going to open the A1 pulley, as you see here. We're going to make sure we separate the FDS from the FDP. You want to make sure you harvest the correct tendon and not the FDP. And we're going to take 2 tendons. There's our FDS test. So here are the 2 FDS tendons, the long and ring, obviously not innervated by radial nerve, but rather median nerve. And here they are retrieved into the forearm. For our passage through the interosseous membrane, we go directly adjacent to the radius. We find the interinterosseous vessels, and we make a big window into the membrane, directly proximal to the pronator quadratus, which you see here. And then we shuttle it to the back. We love to use transverse incisions because they're more aesthetic, and they, especially on a young girl like Julia, and they heal much better. So we're passing this from the front to the back. This is for the one that's going through the interosseous membrane. We leave the FDS tendon in the arm as long as possible. So we use these series of Penrose drains. For our insertion site, we prefer to go around the long finger metacarpal. We do not try to attach it to a small extensor carpi radialis brevis or longus tendon. The metacarpal is a great anchor. We'll use these arthroscopic or loops type to pass it. And then this is the FDS transfer that's going around the radial side. If you decide to pass them both through the membrane, for some reason you get a supination moment, which can be incapacitating. So one goes radial, like you're seeing with this Penrose, and one goes through the interosseous membrane. So now we're making all the tunnels. This is just for wrist extension here. Once everything is set, so there's loops around the long metacarpal, our Penrose drain shows our tunnels. We have a passage through the interosseous membrane, and we're making one last subcutaneous tunnel from our shuttle incision out to the long metacarpal. So there's our last. And you see this crazy amount of Penrose and crazy amount of sutures. It's almost like sports medicine here for a second. But here's our last passageway. And then once we're all set, then we're going to go back to the volar side. We'll cut the FDS tendons and we're going to transfer them from the front to the back. So here is our last Penrose type of drain. So now everything's set, tendons remain moist. We're going to put a suture in the FDS tendon distally, just where the A1 pulley was, because every now and then the tendon will get stuck in the carpal canal and you have to retrieve it. And we'll use what we call a triple threat. So it's an Alice to wind it up, a freer that goes underneath, and then a knife. That's our triple threat. We're going to cut one tendon, or cut the other tendon, and then you're going to pull it into the distal forearm through the carpal canal, as you see here. It's a little bit of a tug. You get these minor attachments. Just be the ball and pull pretty hard. And then here's the other tendon being pulled through. So now the ring and long finger FDS tendons have been cut into palm, pulled through the carpal canal, are now in the back. Now our goal is to pass one radial and one through the interosseous membrane like you see here. So here is the one tendon going from the front to the back through the membrane, and now it's going out to the long metacarpal. Notice it does not stay outside of the wound very long, so it's staying nice and moist. And then we're going to pass our second one, as you see in a second, from along the radial side. So now both FDS tendons have been transferred from the front to the back, and they're about to be sutured around the long metacarpal. Typically, one goes radial to ulnar, and one goes ulnar to radial with these whip stitches, as you can see here. Now, at this time, everything gets closed. So everything's closed. The only thing that's not closed is the incision, the transverse incision of the long metacarpal. And then the tendons are passed, again, one way, one the other way. And then we're going to set our tension for our tendon transfer, maintaining the wrist and extension, right? Sometimes the suture breaks, just grab it anyway. That happens, as you can see here. And then we're going to suture them. So that's our FDS technique that we prefer, and we no longer use pronator teres unless we're in dire straits. Then we're going to transfer the flexor carpi radialis to the EDC, as you see here, again, passing it from the front to the back. We're going to weave it through the EDC, as you see here. We do we don't do as many pulver tafts, typically one pulver taft, and then end aside anymore. And then again, EPL to palmaris, not palmaris to EPL. Because if you transfer the EPL to the palmaris, you get better thumb retropulsion without any thumb adduction. And here she is at 3-month follow-up. Just get this clip running. Right, so this is Mike Aversano, our hand surgeon, who's at Ortho Carolina now. That's her wrist extension. Right, very little therapy, just really rocking wrist extension. Why? Because FDS and wrist extension are synergistic. Here's her finger opening. Now, they always require a little bit of wrist flexion for finger opening, but you'll get a sense in a second how good her finger extension actually is. I'll take that. I think that's pretty good finger extension at the metacarpal phalangeal joint from the FCR to the EDC. And then she's going to show you her EPL to palmaris longus transfer. Notice how it sticks straight up in the air without any thumb adduction. She's able to palmar abduct from a median nerve innervated thenars. And that's just really, really good thumb extension. So that is our preferred technique of tendon transfers for high radial nerve palsy. Again, wrist extension, metacarpal phalangeal joint extension, and thumb IP extension and thumb retropulsion at the same time. And real quick, a little bit of a suggested reading list. For those who really want to do tendon transfers, I think there's two favorite books. Paul Brand's book on clinical mechanics of the hand has always been my favorite. And then Dick Smith's book on tendon transfer of the hand and forearm. This is miraculous reading that I give to my fellows. And then Paul Brand also talked about The Gift of Pain, another suggested reading list. And with that, I will stop, Harvey. Thank you very much.
Thank you, Scott. That was a fantastic case and really great results. Thank you so much for sharing. Neil, could we try to have a look at your slides again, if that's okay? Would you mind trying to share it?
I really apologize.
Yeah, no worries.
Can you see now?
Yes, we see you.
Fantastic. Hopefully.
Okay. Yeah.
Oh, yes.
Yeah. Yes, we see you.
Fantastic. So
Yeah.
I apologize. So obviously Scott has just been over tendon transfers, but essentially we use pronator teres to ECRB. It gives great wrist extension. And then you can use either FCU or FCR or FDS to get finger extension. And then for thumb extension, use palmaris or one of the FDS tendons. And obviously, a new concept is to use nerve transfers. And the two, essentially by Susan McKinnon, which is using one of the nerves to one of the FDS tendons to the nerve to ECRB, and then the nerve to FCR to the posterior interosseous nerve. Bertelli in Brazil has suggested using the distal AIN to the nerve to ECRB, and then similarly using the nerve to FCR to the posterior interosseous nerve. So we wanted to look and see how much literature there was to compare tendon transfers, tendon grafts, and nerve transfers. And in fact, there's a huge literature on radial nerve transfers, but there are very, very few comparison studies. And essentially, there are only 29 studies since 1946. There are 17 that deal primarily with tendon transfers, 8 with nerve grafts, and 9 with nerve transfers. And the problem with comparing these is that there's a lot of grading scales that are used to assess the results. And so what we had to do was to try and compare all these grading scales. And we decided just to make it very simple and make a grading scale that's good, neutral, and poor. So when you look at the 29 studies, there are 754 patients. 351 had nerve grafts, and those were done primarily in the late 40s, the 1950s and 1960s and the early 70s, both from the Second World War and the Korean War. And then there are 339 tendon transfers, and obviously because nerve transfers are relatively recent, there are only 64 of those in papers in the literature. And so we came up with this good, neutral, poor system. And this is just to show you the comparison. So most people use the Medical Research Council's grading scale. And 4 to 5 is good, neutral is a 3, and poor is 0 to 2. The BINCAS and the Zachary scales, there are 169 of those and 147. And then the others, the Louisiana State University system and the House system, have very, very few patients in them. So if you take all the tendon transfers, the nerve grafts, and the nerve transfers, overall, the good results were seen in only 113 of the nerve grafts, which was 32%. In terms of the tendon transfers, it was seen in 277, which was 82%. And in terms of the small number of nerve transfers, 38 out of the 64, which is 59%. Now we can break this down into assessing the results at the wrist, and we can assess the results also in terms of the fingers and the thumb go together. So again, if you just look at the good results at the wrist with a nerve graft, it's less than 50%, 46%. Tendon transfers are by far the best, with almost 100% at 96%. And then a nerve transfer has about a 71% chance of getting you good wrist extension. In terms of finger extension, again, with a nerve graft, it's still only around about 52%. The incidence of good results in tendon transfers for finger extension drops slightly from that 96% at the wrist down to 77% at the finger level. And the nerve transfers also drop very slightly at the finger level from 71% down to 68%. And this is just showing you the same thing again in terms of the nerve graft, about the same at the wrist and the fingers. Again, slightly dropping in terms of nerve transfers from the wrist to the fingers, and also with a nerve transfer. So the bottom line of all this is that the tendon transfers are far superior to nerve grafts or nerve transfers. And if you look at the wrist level, they're vastly superior with a p-value of 0.001. And the same at the finger level. Again, it drops slightly down to 77% with tendon transfers, but it's still superior to nerve transfers and nerve grafts. So our conclusion from this paper is that tendon transfers still objectively are much more guaranteed than nerve grafts or nerve transfers. And tendon transfers can be activated within 4 to 6 weeks of the operation, which is much, much faster than doing a nerve graft or a nerve transfer, which may take up to 9 to 12 months. Obviously, any nerve transfer or nerve graft is dependent on axonal reinnervation across either 1 or 2 nerve coaptations, and nerve regeneration may only partially occur, or it may be a complete failure. And therefore, they're much less predictable than tendon transfers. I think the only advantage of a nerve transfer, in my opinion, would be that they may allow you to do simultaneous wrist extension and finger extension, which you can't really do with a tendon transfer. And that was shown a little bit on Scott's video. So just looking at what's been written previously, the latest papers on tendon transfers, Karabeg and Masavi have both shown that FCR and FCU and the FDSs are all pretty similar. And in fact, there's a paper by Yavari which shows that you can use FCU not only to give you wrist extension, but also to give you finger extension. This is Susan McKinnon's work. She had actually 17 radial nerve palsies and 2 PIN palsies. And she got a 93% recovery of wrist extension with her nerve transfer. But this drops dramatically when you try and get finger extension. And only 63% of those patients recovered just M4 finger extension. If you look at there are really only a few papers on nerve transfers. We've talked about Susan McKinnon's paper. Garcia Lopez had 6 patients and said that he got a recovery of M4 both for wrist and fingers. But there's a paper out of Egypt with 21 patients, and they really didn't even get a 1 in 3 recovery either of wrist extension or finger extension with nerve transfers. And then the latest study by Batelli, where he compared both nerve grafts and tendon transfers, he got very good recovery of wrist extension, but again, it dropped to get finger extension. There is really no randomized controlled trial of tendon transfers versus nerve transfers. There is a systematic study by Compton in 2018, a much smaller number of 106 tendon transfers and 25 nerve transfers. And he got equivalent wrist extension, but again, only M4 with the nerve transfers. And then, as I say, Botelli's study showed pretty good wrist extension, but it starts to drop off in terms of getting finger extension. And the big difference between a tendon transfer and a nerve transfer is that potentially a nerve transfer may give you simultaneous wrist extension and finger extension in about 57%, compared with less than 1 in 3 with a tendon transfer. So that's my set of slides on our study of nerve transfers, nerve grafts, and tendon transfers.
Great. Thank you so much. That was really fantastic.
I apologize for the auto-visual to start with.
Yeah, but no worries. I'm glad it worked out. I'd like to invite Mr. Yong now to give us a few comments on your thoughts about nerve and tendon transfers for radial nerve palsy.
Okay, well,
Yes.
in the interest of time, I just have 3 comments. Firstly, I agree that tendon transfers are good and have many pros, like very predictable outcomes. Surgery can be done at any time post radial nerve palsy, provided that the joints are supple. However, but it shouldn't be done too early. Right here, I will quote Tobias's comment that early transfer to ECRB is useful because it acts as an internal splint and presents little inconvenience when nerve regeneration takes place. However, it is not true for early transfers to the finger thumb extensors. These transfers risk hindering the flexion if the nerve recovers. Secondly, the optimal results of nerve transfers and tendon transfers are both operator dependent, right, in surgery and in rehabilitation. For nerve transfer, it is time dependent. That is, surgery should be done before 6 to 7 months post-injury. This is a caveat for good results. Of course, the other caveat is synergistic nerve transfer. The authors commented that better results with nerve transfers in Botelli's study is biased, as nerve transfer surgeries were done less than 6 months post-injury, and tendon surgeries were done greater than 15 months post-injury. And this represented 2 distinct populations. My comment is that the results of tendon transfer surgery is not time-dependent, whereas for nerve transfers, right, it is time-dependent. So the author's data included nerve transfers being done at 3 to 12 months post-injury. So this is not a good database, right, for the outcomes of nerve transfers. So finally, yes, tendon transfers should be mentioned as an option for treatment, right, for radial nerve palsy, as the authors recommended. But I would not agree that what the authors say that it should be recommended as a first-line option, right, in view of your study of more reliable outcomes. The comments that outcomes of tendon transfers are superior to nerve transfers is, of course, debatable. There are pros and cons, right? So I would reserve tendon transfer surgery for cases with no recovery at greater than 6 months post-injury. Thank you.
Great. Thank you so much for your wisdom and comments, Mr. Yong. So we're actually running over a little bit. We have actually 1 minute for discussion, but I want to ask the panel very quickly a very important question that I think. So the takeaway message for this audience, right? So should we be doing nerve transfers or tendon transfers for radial nerve palsy? So obviously, I know a lot of us do a lot of nerve transfers for different reasons, but do you think we should be doing nerve or tendon transfers for radial nerve palsy? So I guess we'll start with Scott. What do you think?
No, I think both are viable options. The issue I have with nerve transfers is I'll never take a nerve that I may use their tendon. In other words, since I like FDS so much for wrist extension, we will not use an FDS tendon to augment an FDS nerve to regain wrist extension, because just like Neil said, our tendon transfers are just more reliable. So I think when you're selecting your donor, you need to make sure that that you have a backup. Does that make sense?
Yes.
And we've done a bunch of tendon transfers for finger extension in persons with spinal cord injury, but that's supinator to PIN, which works very well. But the supinator is not available, obviously, in a radial nerve palsy.
Yeah, you meant nerve transfers, right?
I meant
Supinator.
nerve. I'm sorry.
Yeah,
Yeah, I'm sorry.
Yeah, I totally agree about the tetraplegia. Neil, you want to say something as well?
I mean, I may be being very dogmatic here, but I cannot see any argument for doing a nerve transfer in a patient with a pure radial nerve injury. It makes no sense, because with a tendon transfer, you get far better strength in wrist extension and finger extension, and you get it within 6 weeks, as opposed to the potential of waiting minimum of several months afterwards with a nerve transfer that may or may not work and may give you less than M5 function. So I think nerve transfers have a part to play, let's say, in an ulnar nerve palsy, but I don't see any part for them to play in a radial nerve palsy.
Okay,
Now, I
thank
may
you.
be biased, but that's my opinion.
Well, that's the message of your paper.
Yes.
It's a very valid one. Mr. Yong, so do you prefer tendon transfers or nerve transfers for radial nerve palsy?
As I said, we have to give a chance for nerve recovery, right? In a nerve injury, right? So we shouldn't go straight away, before 6 months or 3 months to do tendon transfer surgery. It's of course different from Scott Cozin's patient. That's a different scenario. So if there's a nerve injury, I would give time for the nerve recovery before embarking on tendon transfers. I agree. I also have a very good outcome, very predictable outcomes for tendon transfers. So as I said earlier, I would reserve tendon transfers if there's no sign of nerve recovery, etc. Yeah.
Okay, and then just very quickly, since we're running short on time, I'd love to hear from Michiro, Sandeep, Praveen, Kyle. Do you all prefer nerve or tendon transfers for radial nerve palsy? Just one or the other.
So I think in acute phase, we prefer nerve transfer or nerve repair. But in the chronic phase, I do the tendon transfer. Thank you.
Yeah, I like to do tendon transfers.
Yeah,
I'm all tendon.
Oh, Kyle, go ahead.
Yeah, I was going to say I do mostly tendon transfers. The only time I'll do a nerve transfer is if I think it's a young patient early on after injury, where I think it's extremely likely I'm going to get a good outcome. Otherwise, tendon transfers work well.
And Sandeep?
Yeah, I've always had good outcomes with tendon transfers. The few nerve transfers, distal nerve transfers, my outcomes have been suboptimal. So I prefer tendon transfers most of the time.
So I think the consensus seems to be that tendon transfers are preferred. I'm the same. I tend to do more tendon transfers for radial nerve palsy, but like Scott, I do nerve transfers for a lot of other different indications. So Tao is a question, and then we're going to move on to the next paper.
I wanted to ask Scott a question about, you mentioned a few times that you prefer FDS for wrist extension. I think there's still a lot of people that will use the pronator teres, and I just wondered what your thoughts are about why the PT has not worked as well, and just your experience with it.
Yeah, so it's a great question, Kyle. So I think there's a couple reasons. I think synergy goes a long way, especially in children, and there's very little therapy after FDS for wrist extension. I also think that finger flexion, both extrinsic and intrinsic, generates a lot of wrist flexion force, right? And that's can easily overcome an isolated pronator teres transfer, but it doesn't overcome an FDS transfer. Neil says no, but maybe my patients in Philadelphia are stronger than those in California. But I don't like trying to. I know they're right next to each other. The pronator teres is a crappy tendon, crappy periosteum, and it's never satisfying. The FDS around the long finger, I'm telling you, if you try it, you will like it. I've convinced Mike Solomons to do them in Africa, and Francisco Soldado do them in Barcelona. So I just think it works for me better than a pronator teres.
I get great results with pronator teres. What you have to do is you see all these descriptions of people peeling periosteum off the radius to so-called elongate the pronator teres. What you do is just take a longer length proximally of the ECRB, and then you can weave it into the pronator, and it's incredibly strong. So I have never had any problems with great wrist extension just using the pronator.
Well, Harvey, one more comment and I'll let it go. Just from what Neil said, I think is really important. You need to make sure in your patient selection, for example, there's no C7 involvement in some way, shape, or form. Because C7 involvement, again, different patient populations like brachial plexus palsy, will yield a weak pronator teres, which will no longer be a usable donor for wrist extension.
That's a great point.
All right.
Thank you so much.
All right, let's great discussion. We're going to move on to the second paper, which is entitled Options for Restoring Finger Extension in Mangled Forearm Injuries. And first, we're going to have Dr. Bhardwaj, who's going to present slides about this paper. So please, take it away, Praveen.
Yeah, are my slides visible over there?
Yes, yes, perfect.
Yes, yeah. So good morning from India. I'll be presenting this paper, which gives us some uncommon options for restoring finger extensions in mangled forearm injuries. We know that there are a lot of options for doing tendon transfers for finger and thumb extension, but all of these donor tendons are below the elbow, and that is the one which most commonly we require. But in mangled injuries like this, where whole of the forearm is shattered, we don't have any tendons available below the elbow. So in such cases, we need to explore much proximal options. So we know that all the time we have a free functioning muscle transfer available, but most of these patients would be initially undergone revascularizations, making the free functioning a little bit more challenging. We can have a latissimus dorsi extended with fascial graft. That is also one option. The new 3 options which are available for restoring finger extension or wrist extension, which have been described, are brachialis by Bertelli, where he has used it for restoring wrist extension and finger flexions. However, we generally like biceps for finger flexion, and which regularly we have done for brachial plexus injuries, and because we find that the biceps tendon is quite nice to give a strong attachment, and it allows early mobilization, which is much more nice since you are using a fascial graft and you don't want it to get adhered in that track where you have passed it. Also, an interesting option is triceps long head transfer, which has been shown in a single case where it provided good result in this patient. Now, in these 2 patients which we have presented in this article, for one patient we have used a biceps for finger extension, in other case we have used triceps for finger extension, and I will tell why. So this patient had a major crush injury, revascularization. He finally healed after a flap covers over the forearm and the volar aspect. This patient achieved decent amount of finger flexion by mass repair of the flexors, but he lacked finger extension. And since his wrist was stiff, he was unable to use the tenodesis effect to open up the fingers and use the hand. And that is the reason why we thought we should go for restoration of finger extension. At this time, we had the biceps available, and biceps brachialis both were working, and we thought we can take the biceps and put to the finger extensors. Since his forearm was quite stiff, we were not worried about losing supination in this patient because it was fixed in supination. The biceps was extended with a fascial graft. We tunneled it under the mobile wad so that it can act like a pulley. And this patient tendon are distal available only in the dorsum of the hand. So we had a big fasciolata graft attaching to the fingers. And this is the level of function we could achieve in this patient. You see decent amount of flexion and the fingers opening up quite well at the MCP joint, at the IP joints. And this is what we got from the biceps to finger extensors. He could use this function quite well, because this extension of the fingers allowed him to open up the fingers to grasp an object, and he was able to quite comfortably go and pick up things. The second patient where we had total loss of the tissues on the volar aspect, this patient also underwent a revascularization of the forearm. And since all the tendons over the volar aspect were injured, we were unable to have any tendons available for doing a transfer. So in this patient as well, once the healing was restored, he had decent amount of finger flexion, but there was no finger extension. And since his biceps tendon also was injured, we thought of using the long head of triceps for finger extensions. The long head was harvested, which is separated out from the medial and the lateral head. It is extended with fasciolata and attached to the digitorums. This long head tendon is tunneled over the anterior aspect of the elbow. That is to get an tenodesis effect for with the elbow flexion. It is tunneled under the mobile wad and then attached to the extensor digitorums. In such a manner, this is the fasciolata which would go anterior to the elbow, then under the mobile wad and attached to the digitorums. This is the intraoperative photo which shows how good this tenodesis effect could be achieved when the tendon is going on the anterior aspect of the elbow. As the elbow is extended, we would see that the fingers are extending quite nicely. So that is the reason when we are putting a triceps to finger extensor, it is always good to get it anterior to the elbow so that you can make good use of the tenodesis effect of the elbow. This is the scheme of the tendon transfer, the triceps long head extended with fasciolata coming anterior to the elbow, then under the mobile wad and attached to the digitorums. The good thing about this transfer was we could start the physio right on the day 2 itself. And the patient is extending the elbow, and that is the time he is contracting the triceps. So it is very easy to teach to the patient. He has to just contract the triceps, which extends the elbow, and it uses the tenodesis effect, and you can immediately see that the fingers are going up. So we like this transfer, the triceps transfer, more than the biceps transfer because it is much easy to rehabilitate the patient. And this is the outcome we could achieve at 1 year. Good amount of flexion and almost complete finger extension at the MCP joint. This is again a video showing how much of finger extension could be achieved with this transfer. It was a nice thin patient, so we could even see the track of our fasciolata, how it goes anterior to the elbow, then under the mobile wad, and it is able to give decent amount of finger extension in this patient. So that is the 2 articles, two case reports we have published in these articles. To summarize, when the regular donors at the forearm are not available, we can go more proximal. Common options which can be used are brachialis, which is basically used telling that if we don't want to take out biceps, we can take brachialis. But I think taking out biceps is not a problem. It does not cause any much disability. You have a good tendon tissue, you can get a good repair, and you can mobilize the patient early. However, out of all these options, I would say the triceps long head is the best, because since the tendon transfer can be rehabilitated much easily, and if there is no deficit, I would prefer this as the first option if it is available. And Here, the tendon transfer, as it goes volar to the axis of the elbow joint, the tenodesis effect allows the patient to extend the fingers. So training them is just about telling that you contract your triceps, do the normal elbow extension, and that would create a good amount of finger extension. And since the triceps has a good excursion, it is capable of producing a full finger extension in these patients. So if you don't have a regular options of FCU, FCR, FDS available, I think this is the way to go. Thank you so much.
Excellent presentation. Those were fantastic cases with great outcomes. I would next like to invite Professor Yong to provide some comments on this article.
Thank you. This was fantastic, nice cases. I just like to comment on some principles and things that were done in these two cases. So, oh, sorry. Look at the first slide. No. Yeah. Okay, that's my first slide. So we know that the scenario, right, in these two cases were there no suitable wrist or finger flexors for transfer, and I didn't have the privilege of seeing the video, but in preparation for this presentation, I was asking whether there was any entry power in the ward, mobile ward muscle, as in the case of the tricep transfer, and whether there was any entry wrist flexor present. So looking at the video, there isn't any wrist flexion possible. So the options as mentioned, so I was looking at it, if there was some wrist flexion, the other option would be ADC tenodesis for finger extension and plus BR transfer to the ECRB for wrist extension to increase the flexion grip power. The options chosen by the author were these two. So commenting on the technique of the biceps tendon transfer, we know that the biceps cross volar to elbow joint and also to the wrist joint. And tensioning of the tenorrhaphy, as was mentioned, and we have to check that with elbow flexion, full passive flexion of fingers are possible. However, there is no mention of keeping or maintaining the resting length of the biceps in the technique, as we know that the maximum tension, right, of the muscle tendon is at the resting length. And there's no mention of synchronizing the EDCs, so I suppose the tendon is weaved into each EDC separately. For the triceps long head transfer, the path of the triceps crosses anterior to the elbow joint, under the mobile ward, and dorsal to the wrist joint. Tensioning the same. With the elbow flexion, there should be full passive flexion of the fingers. However, similarly, there's no mention of keeping the triceps long head at the resting length to have maximum strength tension, and no mention of synchronizing the EDCs. As I said, I couldn't see the video clip beforehand. So trying to explain the transfers, so the biceps transfer to the EDC partly depends on the tenodesis effect to achieve greater excursion of the finger extension, and plus the active bicep contraction at the 45 degrees. For the tricep transfer, There's active triceps contraction, but in addition, have to depend also for the tenodesis effect to achieve greater excursion. Rehabilitation, as I mentioned, active muscle contraction plus the tenodesis excursion. We know the excursion for finger thumb extensors about 50 mm, right? And the biceps excursion with the range of motion of 30 degrees about 24 mm, right? For BR is about 33 mm. So how to overcome the deficit in the excursion, right, is resolved by the tenodesis effect of the tendon joint motion, right? So MCPG extension 50 mm, right? So you need the wrist flexion and extension to get the maximize MCP extension tendon excursion. Right. So as mentioned earlier, triceps transfer is synergistic for finger extension, so retraining is easier. Biceps is not synergistic, so retraining is slightly harder. Just to illustrate this tenodesis effect, right? Both transfers have done what we call the cross-dynamic tenodesis, as in the tendons pass on both sides of the joint, the axis of the joint of rotation, right? So rotating one joint will lead to rotation the other joint in the same direction. Thus, in the biceps tendon transfer, right? So the exercise is to extend the elbow extension that will cause a tenodesis effect on the wrist to extend, right? But in this case, the wrist is a bit stiff, so the extension into the EDC would be tenodesis that crosses on the same side of the joint. So with the wrist maintaining the flexion, we have tenodesis effect to extend the MPJ. Right. So the distal part, the wrist a bit stiff, would be the principle of direct dynamic tenodesis, right? So the extension of the biceps or triceps tendon to the EDC would rely on this principle, on that means the tendon crosses one joint. So with the wrist remain steady, right, then the tenodesis effect will cause the extension of the fingers. Right. So the result of biceps transfer to the EDC as published in the paper, we know that the wrist joint is controlled. Thus, the EDC extend the MPJ. Right. We noticed that in the top picture, when the fingers flex, the wrist extends a bit, right? So this is the principle of reverse tenodesis effect. So a comment here that actually, if we have some, so we noticed that the fingers, opening the fingers, the PIPJ is not really to full extension, but it's sufficient, as we saw in the video on his hand function. But if we want further PIPJ extension, so this KIV to add the tendon graft intrinsic plasty as described by James House. Just to illustrate the case of ADC tenodesis, in the case of bilateral tetraplegia, right, OCU5, group 5, after the EDC tenodesis to the radius, this is the result. So with wrist flexion, finger extend, wrist extension, finger flexion. So post-op, good extension, flexion. Thank you.
Great. It was an excellent presentation. I'd like to ask Scott Kozin to make a few comments about this paper, please.
So Kyle, as always, when Praveen presents something, I always learn something. So I think remarkable when you're in dire straits, what you can reach to get a tendon. We have used the biceps, mainly in tetraplegia for biceps and triceps, but we have used biceps in dire straits to augment either wrist or finger extension. I think it is, it's like a kind of keep in your back pocket if you really need something. It's clearly not our first choice, but kudos to Praveen and kudos to the comments regarding this particular transfer. It's not easy to do, and the results are exceptional as usual.
Great. Thanks, Scott. I'd like to open it up for questions. If there are any from the audience, please put them in the chat. I wanted to start by asking, how you would consider this for Dr. Bhardwaj. How would you consider these transfers versus a functional muscle transfer? Obviously, at Ganga, you do tons of functional muscle transfers. So how do these transfers fit into the armamentarium when you can do a functioning muscle transfer?
Yeah, I think for finger extension, we maybe only 2 cases we have done a free functioning muscle transfers, but these 2 cases, since they had a very the long vein graft going from the brachial artery to the ulnar artery, here we were a little bit hesitant to do a free functioning muscle transfer, and that is the reason we started thinking of the other options. So actually, while writing the paper only, we realized that this is already a published technique, but we have not read the technique, and it was only the thought process that the triceps long head could be used for restoring finger extension, because we have used the triceps long head transfer for elbow flexion for many brachial plexus patients. So we know that it has got a good amount of excursion. It can be separated out well, and the long head really appears to be a tendon which can do a good amount of finger extension. So these patients, once after doing this, I think we will not keep free functioning as the first option. We would, if the biceps, triceps not available, then only we will think of a free functioning transfer.
Great. Professor Yamamoto or Sebastin, any comments or questions about this technique?
So I want to ask about the biceps to finger extension. So how did you treat the biceps tendon to the fascial lata for suturing?
Yeah. So biceps tendon, the fascial lata was weaved into the biceps tendon, and it was tunneled under the mobile wad. So mobile wad was acting like a pulley for it so that it does not pop up too much. And then it was tunneled under the dorsal aspect skin. The patient had a flap over there, so it was tunneled under the flap and attached to the finger extensors. So
you don't cut the biceps tendon.
Biceps tendon is totally, we cut. It was totally divided. Yes, sorry. Yeah.
Totally divided. Oh, okay.
Totally divided. Yes. So totally divided, and then it was rooted with the fascial lata going to the dorsal aspect. Yes, it was totally divided, and I get that point because actually I think we need to divide it fully. We cannot do in continuity transfer. If we do an in continuity transfer, the excursion of the tendon is lesser and you will not get a good finger extension. So we must divide the tendon completely, yes.
But no problem of the elbow flexion because of the brachialis or brachial
This patient had normal brachialis, so he didn't have any deficit of elbow flexion. There may be a small concern about losing supination. But if the supinator is intact, we will not lose supination. And this patient in particular had a fixed supination deformity. So that gave us more confidence to take away his biceps. So he didn't have any deficit at all. Yeah.
Okay, thank you.
So Praveen, I have a question. First of all, congratulations on your outstanding results. Amazing work you guys do. How do you guys actually teach patients to independently use the long head of the triceps? Like a biceps and the brachialis I get because, they'll flex their elbow in supination and pronation, but how do you teach the patients to rehab and use the long head of the triceps as opposed to the other heads?
Yeah. Actually, after experience with these 2 patients, we felt that training a patient for triceps was much easier. Now, for the biceps to finger extensor, when the patient is contracting the biceps, the elbow flexes, which relaxes the transfer. So we need to really teach a patient that he should tighten the biceps without flexing the elbow. Then the transfer would be powered. But when we have done a triceps to finger extensor, the training was much easier because since the transfer is going anterior to the elbow, when patient is doing a normal elbow extension, like we just tell him to extend the elbow, so he is powering his triceps, and at same time, the tenodesis effect is extending the finger. So we on the second day itself, after the dressing change, patient is put on a splint, and he is asked to do active elbow extension. With active elbow extension, he is powering his triceps, and at the same time, the tenodesis effect is extending the fingers. So it is much easier to train the patient. In 1 week itself, they learn how to power this transfer, and then they go home and do the exercise themselves. I think it is training is easier for them.
So you don't actually teach the patients to independently extend the fingers, but it's always with the elbow extension together, right? That's my understanding.
Yes, right, correct.
Thank you.
We only tell him to extend the elbow, and that would be extending the fingers.
Professor Sebastin or Jones, any other comments or questions about this technique?
Yeah, hi, Praveen. I had a patient with a forearm loss of soft tissue for whom I did a biceps to finger flexion transfer. And in order to create a tunnel, I put a silicone rod at the time of the flap coverage. However, when we went in to do the TFL graft, I found that there are significant adhesions. While the patient had some flexion, I think it's very difficult to have a gliding surface of a long TFL graft that extends from the elbow till beyond the wrist. And although we started early mobs, it didn't function so well. So this is just to say that the biceps for triceps biceps for EDC, which you had poor results, I've done it for finger flexion with below average outcomes. Also, the amount, I agree with Scott Kozin that the amount of extension required is probably, so I recently had an elbow amputation through elbow, which required elbow fusion. So both biceps and triceps were available. So I used the triceps for finger extension. And the plan was to use the biceps for finger flexion, but his finger flexion recovered simultaneously, spontaneously. So then I used the biceps for wrist extension. And when I asked the patient, so here we have a triceps for finger extension and a biceps for wrist extension. And his function improved because of the wrist extension. His finger flexion power was much better. The amount of finger extension we gave was not so important, but the amount of wrist extension that suddenly made his grip better was more significant to him. So I feel that if we transfer the triceps to wrist extension, make it stronger, the finger flexion will improve. Basically by a tenodesis effect. And that may be more useful compared to giving a slight degree of MCP extension. Anyway, we all do 1 or 2 cases. It's not that we have a series to talk about, but it's just sharing what I just learned. Thank you.
Great. I guess there's one question in the chat for Praveen. Is there any risk of radial nerve injury while tunneling underneath the mobile wad? I would imagine that many times, if you're going to use this, the radial nerve is not working particularly well, but the PIN is. But I don't know if you want to comment on that.
Yeah, I think this transfer when we are doing the radial nerve is not functioning. But even then, I think there is no risk of causing the posterior interosseous nerve injury because the mobile wad, when you are going, it is much superficial and the nerve is much deeper. So we always put one incision there, hook onto all the tendons, and then tunnel it across. However, the procedure when it is being done, the radial nerve is not functioning in those cases.
Great. Well, I think we're running up on time here. We're just a few moments over. So Harvey, I'm going to turn it back over to you. I know you have a few slides to conclude here.
Great. Thank you so much, Carl. So just a few slides to end off. So please remember to claim CME for Hand in Focus. CME credits can be claimed once every 6 months for all AHS webinars. And please consider applying for AHS membership. So I actually head up the international committee for the AHS, and we really would love to have more international members. You get a, the membership fee is very much discounted. You get a subscription to the Hand Journal. So do please consider applying for AHS membership in the international category. And if there are any questions, please feel free to reach out to me directly. And candidate membership for trainees is free. And I think Sandeep had a few comments about the Asian Pacific Journal.
Yeah, so all our articles in the online ready section are free to access. Please subscribe to the table of contents. So till the issue becomes active, the articles are all in the online ready section and they are free to access. So essentially the entire issue is free to access before it comes on schedule. So please subscribe to the table of contents. We are trying to move up in life. Thank you.
And please join everybody for the APF SSH meeting as well in Mumbai in September of 2025. That promises to be an exciting meeting. And
thank
please,
you, Harvey.
Yeah, and please watch out for our next journal club, Hand and Focus. So again, I like to thank all our speakers from the US and Asia. Thank you so much, and Neil, for joining us from London. I know it's very late at night, so we really appreciate you joining us. There are so many questions about tendon transfers that I think we've only really begun to scratch the surface tonight. So I hope this was really educational for everybody. And again, thank you so much for joining us, and have a good day, everybody, whether it's morning or afternoon or evening, wherever you are. Thank you so much, everyone. Hope to see you all soon.
Thanks, Harvey.
Take care.
Bye, everybody.
Thanks, everyone.
Yeah, have a great
Thank
day.
you.